You good? Let me ask all of our guests to go ahead and be seated. And the Subcommittee on Health will now come to order. I recognize myself 5 minutes for purpose of an opening statement, and I want to thank everyone for joining us this morning to discuss a topic that's important to each and every one of us. This is a subject matter that has been brought to the forefront by members of this subcommittee, members of Congress generally, actions of state legislatures, and the media. Having spent 3 decades myself practicing OB-GYN, I believe it should be a national goal to eliminate all preventable maternal mortality. Even a single maternal death is too many. All too often, we've read about the stories of seemingly healthy pregnant women who are thrilled to be having a child, and then to everyone's surprise, suffer severe complications, death or near death during a pregnancy, birth, or postpartum. The death of a new or expecting mother is a tragic event that devastates everyone involved. And if there are preventable scenarios, we need to do what we can to stop that. The alarming trend in our country's rate of maternal mortality first came to my attention in September 2016, reading a copy of the American College of Obstetricians and Gynecologists, the Green Journal. The original research found that the maternal mortality rate had increased in 48 states and Washington, D.C. from 2000 to 2014, while the international trend was moving in the opposite direction. Since reading that article, I have spoken to providers, hospital administrators, state task forces, and public health experts. The more I looked into this troubling issue, the more I realized that we've got much more we need to understand. This subcommittee had an informational briefing last year on this topic to inform members and to start the road toward this hearing. This is an issue that we cannot solve without accurate data. There were efforts in our nation to address maternal and infant mortality in the first half of the 20th century, and the data showed that these efforts were indeed successful. But according to the Centers for Disease Control and Prevention, the United States maternal mortality rate, 7.2 deaths per 100,000 in 1999, and increased to 18 deaths per 100,000 live births in 2014. The Centers for Disease Control began conducting national surveillance of pregnancy-related deaths in 1986 due to a lack of data on causes of maternal death. In 2003, the Centers for Disease Control National Center for Health Statistics revised standards for certain death certificates and added a pregnancy checkbox. While this checkbox has led to increased data collection on maternal deaths, it does not provide enough insight as to why or how these deaths occurred. Representative Jamie Herrera Butler joining us this morning. The discussion draft that she has put forward will address the complex issue of maternal mortality by enabling states to form maternal mortality review committees to evaluate, improve, and standardize their maternal death rate. This is a critical step in the right direction, as physicians, public health officials, and Congress are unable to reach conclusions based upon current data as to what the causes for maternal mortality increases are. Once we establish what these are, there will be an opportunity to use the data to implement the best practices toward a solution. Texas is a good example of a state that has enacted legislation to create and sustain a maternal mortality morbidity task force. Texas has put time and effort and funding into reviewing maternal deaths in order to find the trends and the increases in the causes of death. The task force's September 2018 report, which I have here and later on will ask unanimous consent to be made part of the record, stated that the leading causes of pregnancy-related death in 2012 included cardiovascular, obstetric hemorrhage, infection sepsis, and cardiomyopathy. This report is just a snapshot of the national picture, as causes do vary from state to state. Additionally, this May, various researchers involved in the review of Texas maternal deaths published a paper, again in the Green Journal, detailing that unintentional user error and other issues led to inaccurate reporting of maternal mortality. The researchers concluded that relying solely on obstetric codes for identifying maternal deaths appears to be insufficient and can lead to inaccurate ratios. The moral of this story is we must ensure accurate data to accurately pinpoint the clinical issues contributing to these tragic deaths. I would like to submit a statement for the record from Dr. Gary Hankins, and without objection so ordered, the chairman of the Department of OB-GYN at the University of Texas Medical Branch in Galveston. And Dr. Hankins was one of those doctors who briefed us during the briefing last year. Dr. Hankins has subspecialty training in maternal fetal medicine and served as vice chair for the Texas Morbidity and Mortality Review Committee. At one time, we were scheduled to be joined by Dr. Lisa Hollier, also of Texas, who is also part of that committee. I think we had to postpone last week because of a hurricane, and she could not accommodate the reschedule, but Dr. Hollier has also been integral in working on this at the state level. So I certainly look forward to hearing from our panel of witnesses today as how we can address this vital and devastating issue. Chair recognizes the ranking member of the subcommittee, Mr. Green. 5 minutes for your opening statement, please.
Thank you, Mr. Chairman, for calling today's hearing on maternal mortality in the United States. And I also like to thank our colleagues and our distinguished panelists for joining us this morning. I'd like to take just a moment, Mr. Chairman. My Deputy Chief of Staff, LD, LA, Sergio Espinosa, this will be his last committee hearing, and he's been working with me on health care in our office for many years, 8 years. It's been 8 or 9. This is his last hearing, and those of you who someday decide you're not going to run for re-election, you'll know that you'll be losing staff members in the last 2 or 3 months. But I just want to thank Sergio for his work in the office on many issues, but particularly in the last number of months on health care. So, and I'll continue with my statement. The Centers for Disease Control and Prevention reports that more than 700 women in the United States die each year due to complications related to pregnancy and childbirth, and more than 50,000 women experience a life-threatening complication. Maternal mortality in our country has more than doubled between 1987 and 2014, from 7.2 to 18 maternal deaths per 100,000 live births. In comparison, a recent World Health Organization study found that maternal mortality is on the decline in 157 of the 183 countries. These numbers are troubling as we are, because even more acute when you look at the existing racial, socioeconomic, and geographic disparities. For example, African American women are nearly 3 times as likely to die of complications relating to pregnancy and childbirth compared to white women. In America in the 21st century, no woman should ever die of complications related to pregnancy and childbirth. Congress has a duty to act and reverse this terrible trend. I'd like to thank my colleagues, both Congressman Diane DeGette and Congresswoman Jaime Herrera Butler, for offering their discussion draft, the Preventing Maternal Deaths Act, that will help protect pregnant and postpartum mothers. This legislation will provide grants to states and tribes to help establish and support already existing maternal mortality review committees, MMRCs, to identify and review pregnancy-related and pregnancy-associated deaths. MMRCs, which are currently operating in over 30 states, have been helping strengthen public health surveillance by linking vital data to the multidisciplinary healthcare professionals practicing in women's health. I support the bipartisan legislation and hope our committee will recommend it in consideration before the full House before the end of the year. While preventing maternal deaths acts is an important first step, our committee can and must do more to protect our nation's mothers. Despite the gains made under the Affordable Care Act, nearly 1 in 7 women of childbearing age remain uninsured. The biggest barrier to women of childbearing age receiving health care coverage is continuing refusal of 19 states, including my home state of Texas, to expand Medicaid. Comprehensive health insurance is critical for expecting and postpartum mothers to receive the post and postnatal care they need for themselves and their babies. Medical research shows chronic conditions such as hypertension, diabetes, heart disease, and obesity, which are becoming more common for expecting mothers, can increase their risk for complications during pregnancy. Ensuring continuity of coverage preceding pregnancy will help women of childbearing age best manage these chronic conditions before they become a problem. Last year, I introduced a Incentivizing Medicaid Expansion Act, H.R. 2688, in order to incentivize states to provide critical Medicaid coverage for uninsured Americans and avoid the kinds of tragedy that has led to the rising rate of mortality in my home state. My legislation would guarantee that the federal government covers 100% of expansion costs for the first 3 years for states that have not yet expanded and no less than 90% afterwards. I ask the committee to give this legislation serious consideration that it deserves and help reverse the public health crisis that maternal mortality and severe maternal morbidity have become too many for our communities in our country. And in my last 39 seconds, UTMB in Galveston has been the catchment for most of the births in East Texas and South Texas, and for decades. And I appreciate that university and that medical school for doing that for our families. In the Houston area, we have a hospital district, but Medicaid would at least help get them reimbursed. But UTMB is the catchment for problem pregnancies in South Texas and East Texas. Thank you, Mr. Chairman. I yield back.
Chair, thanks the gentleman. Gentleman yields back. Chair recognizes the gentleman from Oregon, the chairman of the full committee, Mr. Walden. 5 minutes for your opening statement, please.
Well, thank you, Chairman Burgess. Doctor, we're glad that you're chairing this subcommittee and this subcommittee hearing, especially given your many decades of real-world experiences in OBGYN. So we're glad to have you at the helm for this hearing especially. It's a difficult topic, and it's one that is close to many of us. Far too many mothers die because of complications during pregnancy, and the effects of such a tragedy on any family is impossible to fully understand. What's both surprising and devastating is that despite massive innovation and advances in health care and technology, we've experienced recent reports that have indicated that the number of women dying due to pregnancy complications is actually increasing. It's actually going up. According to the Centers for Disease Control and Prevention, maternal mortality rates in America have more than doubled since 1987. And I think we're all asking, how can that be? Well, this is not a statistic any of us wants to hear. There are questions as to whether the increase is due to data collection or broader questions about health care delivery. The bill before us today will help us answer these really important questions and hopefully ensure that expectant newborn mothers receive even better care. I want to thank Congresswoman Herrera Butler, my neighbor to the north in Washington State, for bringing this issue to our attention. She's been a real leader on this effort for many, many months, if not years, and especially given what you've been through in your own situation, we're proud of you and of your children. And so we're glad to have you before the committee. I also want to thank my colleague and friend from Colorado, Diana DeGette, for her partnership on the draft legislation that is before us today. She's been a real leader on 21st century cures and other public health issues that are so important. And I want to extend a sincere thank you to the members of our second panel. Mr. Johnson, it's good to see you again. We appreciate you coming back here. I'm sorry for what you've been through. But I appreciate your willingness to come share with us. Your testimony makes a difference in public policy. The draft bill we're examining today is the Preventing Maternal Deaths Act of 2018. The bill would enhance our federal efforts to support maternal mortality review committees in each of our states. And earlier this year, the Oregon legislature passed a bill to establish such a committee in my home state, which brings a wide range of medical providers together with community organizations and with public health experts to study maternal mortality and figure out its underlying causes. That information and lessons learned will then be shared with law enforcement and healthcare providers across Oregon. Congress should support, and it should build off of these efforts and others across the country so many of these deaths could be prevented if best practices for maternal health care were followed and more widely understood. So that's what this hearing's all about. We appreciate you being here, and we look forward to the testimony from our other panelists and, of course, from our colleague. I would tell you in advance, we actually have two subcommittees going on simultaneously, and as chairman of the overall committee, I have to bounce back and forth between them. But thank you for being here, and we look forward to moving forward to find solutions. And with that, Mr. Chairman, I yield back.
Chair thanks the gentleman. Gentleman yields back. Chair recognizes the gentleman from New Jersey, Mr. Pallone, the ranking member of the full committee. 5 minutes for an opening statement, please.
Thank you, Mr. Chairman. Hundreds of women die each year from pregnancy-related or pregnancy-associated complications in the United States, and more than 60% of these deaths are preventable. Shamefully, the maternal mortality rate in the U.S. has increased, while in most of the rest of the developed world it has actually fallen. And this is not just alarming, it's unconscionable. We have a responsibility to understand why this is happening and what we should be doing to combat this crisis. Mr. Green and I wrote a letter to Chairman Burgess and Chairman Walden on this issue in May, and I'm pleased we are finally holding a hearing today. Today we'll discuss a draft of the Preventing Maternal Deaths Act, which mirrors a version that passed out of the Senate Help Committee. This is a good bill. It's critical that we have the necessary data to understand the underlying causes of maternal deaths and identify strategies that can help us combat it. This bill encourages states to implement maternal mortality review committees to study this data and make recommendations on ways to combat maternal death. Review committees that are diverse and interdisciplinary can identify trends, patterns, and disparities that contribute to preventable maternal deaths. And with this information, healthcare providers can monitor the effectiveness of their policy and practice changes. Now, my home state of New Jersey was the second state in the nation to institute a maternal mortality review committee, which has worked extensively to review New Jersey's maternal death cases to better understand their root causes and prevent deaths in the future. However, New Jersey's maternal mortality rate remains much too high, and much more work still needs to be done. Extensive public reporting has vividly described the risks American women face in childbirth and the postpartum period, and has also highlighted the vast disparities in outcome. While women of all backgrounds are at risk for pregnancy-related complications, it's critical we also examine why maternal death rates are disproportionately higher for women of color, low-income women, and women living in rural areas. And we must understand why and work together to address these disparities. However, we must also consider other ways we can combat maternal mortality, including by expanding health insurance coverage, ensuring all women have access to reproductive health services they need. Unfortunately, efforts by the Trump administration to sabotage the Affordable Care Act, curtail the Medicaid program, and limit family planning services have only served to harm women and their families. Reducing maternal deaths in the U.S. must be a public health priority, and I look forward to working with my colleagues to advance this bill and to begin addressing this crisis in a meaningful way. And I'd like to now yield the 2 minutes remaining to my colleague, the Democratic sponsor of H.R. 1318, Ms. DeGette.
Thank you very much for yielding. Mr. Chairman, thank you so much for having this hearing. And I know my co-sponsor, Congresswoman Herrera Butler, and I very much hope that we can mark this bill up and pass it during the lame duck session. In my opinion, it's been far too delayed given what we're seeing in this country. Maternal mortality rose in the United States between 2000 and 2014 by 26%. This is really shocking to people who I talk to about this because other developed nations in the world have slashed their maternal mortality rates in half. And here's what's even worse. Maternal mortality disproportionately affects women of color. Pregnancy-related death is nearly 4 times higher among African American women. And there are multiple factors that contribute to these maternal mortality rates. The high incidence of preeclampsia, obstetric hemorrhaging, and mental health conditions. Now, to combat this trend, 33 states have established maternal mortality review committees. These panels bring together local healthcare professionals who collectively review individual maternal deaths and then target individual policy solutions towards them. The panels have been very effective. In California, for example, which established one in 2006, they've reduced their maternal mortality by more than 55%. And that's why what this bill does is it provides federal support for state-based maternal mortality review committees, including for states, critically, that have not yet established these panels. It also promotes efforts to standardize data collection practices for maternal mortality, which will help public health experts, researchers, and policymakers develop evidence-based solutions to address this crisis. The bill has 171 co-sponsors and a number of organizations, some are which here in the audience today, the March of Dimes, the American College of Obstetrics and Gynecologists, and others all support it. And so I really hope we can quickly advance the bill. I hope we can pass it by the end of the year and send it to the President's desk. Thank you, and I yield back.
Chair thanks the gentlelady. The gentlelady yields back, and this concludes with member opening statements. The chair would remind all members that pursuant to committee rules, members' opening statements will be made part of the record. We do want to thank our witness on the first panel for being here today and taking time to testify before the subcommittee. I do want, as a housekeeping note, after Representative Herrera-Beutler testifies, we'll move immediately to the second panel. We will not break in between the panels of witnesses. And again, as is the custom, when we have a member at the witness table, there will not be questions from the dais to the member. So we'll go right into the second panel after Representative Herrera-Beutler testifies. So our first witness is Representative Herrera-Beutler from the state of Washington, who's principal author of this legislation. We appreciate you being here today, and you're recognized 5 minutes for your opening statement, please.
Got to work it myself. Thank you, Mr. Chairman, for having this hearing today and for your work in this field. This isn't an issue of the moment for you, but this is what you've dedicated your life to, and we are very grateful. Thank you, Ranking Member Green, for your support of this critical issue, and members of the subcommittee today for participating in this effort to reduce maternal mortality in the United States, and for giving me this opportunity to speak in strong support of the discussion draft of the Preventing Maternal Mortality Deaths Act that is before us. So you either are a mom or you have a mom. So this issue impacts you. The very title of this bill speaks to why I've introduced this bipartisan legislation with my co-sponsor, Ms. DeGette from Colorado. We have to take vital steps towards moving this bill in Congress, and I believe we're going to save lives and prevent more families from suffering the profound loss of a cherished family member. The testimonies today will shed light on a truly disturbing trend in our nation. More mothers die from pregnancy-related or pregnancy-associated deaths here in the U.S. than in any developed country in the world. Although the assumption is often that a nation with some of the most advanced obstetric and emergency care would also demonstrate low maternal mortality rates, tragically, an estimated 700 to 900 maternal deaths occur in the U.S. every year. And not only does the U.S. rank 47th for maternal mortality globally, we have actually seen an increase in maternal deaths in recent years. This makes us one of only 8 nations in the world with rising maternal mortality rates. It's unacceptable. In fact, Iran has a better maternal mortality rate than we do here in the United States. In New Jersey, where Mr. Pallone is from, and he knows this, if you're a woman of color, a black woman, you're 79, out of 100,000 deaths, 79 are likely to pass away from a pregnancy-associated or pregnancy-related death. You're 3 to 4 times more likely as a woman of color to experience this tragedy in our country. It's unacceptable. For families, single fathers, grandparents, and children who have all lost a mother, perhaps the most heart-wrenching of all of this is that according to the CDC, 60% of these maternal deaths could have been prevented. As a mother, as a citizen, and a lawmaker, I believe we can and we must do better. It is time for this to become a national priority, which is why I'm proud to speak in support of the Preventing Maternal Deaths Act. This legislation would enable states to establish and strengthen maternal mortality review committees. MMRCs bring together local experts in maternal, infant, and public health to review each and every instance of a pregnancy-related or pregnancy-associated death. We're going to investigate every single one because these moms are worth it. This is going to give us the information to understand why it's happening and what we need to do to fix it. This is how we're going to save future mothers' lives. As members of the committee are aware, we know many of the conditions that contribute to high maternal mortality rates, such as preeclampsia, gestational diabetes, obstetric hemorrhage, as well as emerging challenges such as suicide and substance use disorder. However, the truth is that the available data is woefully inadequate, which is greatly hinders our ability to understand why mothers are dying. The Preventing Maternal Deaths Act seeks to address this data deficiency by empowering states to participate in national information sharing through the CDC, allowing for increased collaboration and the development of best practices. Now, before closing, I want to note that the legislation before us was crafted from key policy recommendations made by multiple organizations supporting this bill, including the Association of Maternal and Child Health Programs, the American College of Obstetricians and Gynecologists, the March of Dimes, Preeclampsia Foundation, the Society for Maternal Fetal Medicine. Thank you to all of you tireless warriors in this fight. Finally, and most importantly, I would like to extend my deepest gratitude to the families, fathers, one of whom you're going to hear from today, sitting behind me. Charles Johnson's going to tell you the story of the preventable death of his hero, and hopefully this will be a tribute to ending those tragedies. He wants no one else to go through what he's gone through. And to every advocate who has spoken out, shared their stories, and called for change, these courageous individuals are the champions of this movement and this bill. With wide bipartisan support and well over 160 co-sponsors in the House, I remain committed to passing the Preventing Maternal Deaths Act into law, and I look forward to working with this committee, you, Mr. Chairman, and my colleagues in Congress to accomplish this imperative goal. With that, I thank you, and I yield back.
We thank you, Representative Herrera-Butler, for, number one, putting forward the discussion draft and working on it so hard over this past year and bringing all of the different people together that had to finally come together to get this hearing a reality today. And I know it took a lot of work on your part, and we really appreciate your dedication. So thank you for being with us this morning, and we will move immediately to our second panel. And while the transition is occurring, I'll just use this time to thank all of our witnesses for being here today and taking time to testify before the subcommittee. Each witness will be given the opportunity to deliver an opening statement, followed by questions from members.
Mr. Chairman.
For what purposes, the gentleman from Texas seek recognition?
I'd like to submit the following letters, ask unanimous consent to submit the following letters for the record from the Moms Rising, Alexis Joy Foundation, and the Society for Paternal Fetal Medicine into the record.
Without objection, so ordered. Do we have copies of those?
Yes. Yep.
Is Sergio's resume up online, just by the way? I'm just kidding. So today we are going to hear from Mr. Charles Johnson, founder of For Cura for Moms, Ms. Stacy Stewart, president of the March of Dimes, Dr. Lynn Coslet Charlton, Pennsylvania District Legislative Chair, the American College of Obstetricians and Gynecologists, and Dr. Joya Greer-Perry, President of the National Birth Equity Collaborative. We appreciate each of you being here today. And Mr. Johnson, you are now recognized 5 minutes for an opening statement. Please turn your microphone on, pull it close. This is the premier technology committee in the United States House of Representatives, and we have fairly rudimentary amplification devices. So, Mr. Johnson, you're recognized.
I think I'm managed. Thank you so much. So first and foremost, to the members of this committee, thank you. It is an honor to be here speaking on behalf of the tens and thousands of families that have been affected by this maternal mortality crisis and the hundreds of thousands of women who have been affected by near misses. So let me just begin by telling you about the woman that absolutely changed my life. My wife, Kira Dixon Johnson, was the closest thing that I'd ever met to a superhero. She made me far better than I ever thought I could be, and she was far better than I ever deserved. We're talking about a woman that ran marathons, that raced cars, that spoke 5 languages fluently. So we were blessed to welcome our first son, Charles, on September 18th of 2014. We always wanted back-to-back boys, Chairman Burgess, and we were blessed to find out that we were going to welcome our second son, Langston, in April of 2016. We walked into Cedars-Sinai Medical Center on April 12th of 2016 with a woman that just wasn't in good health, she was in exceptional health. This picture that you see on the screen is literally taken 10 days before Kira went in for the procedure. We went in for what was supposed to be a routine scheduled C-section on what was supposed to be the happiest day of our lives, and we walked right into what was a nightmare. Shortly after the procedure took place around 2 o'clock, shortly afterwards, we went back to recovery. As I'm sitting there reflecting in all this glow and pride of being a new father for the second time, Kira's resting, my new baby is resting, and as I look at her bedside, I begin to see the catheter begin to turn red with blood. I brought it to the attention of the staff, the nurses at Cedars-Sinai. They came in. They said, we're going to do a couple of things. We're going to order a set of tests, and we're going to order a CT scan to be performed stat. I was concerned, but I said, you know what? My wife is healthy, and what's supposed to be one of the best hospitals in the world. I'm concerned, but we've got a plan, okay? Blood work comes back. It's showing that it's abnormal, and she's hemorrhaging. And they ordered a CT scan that was supposed to be performed stat. Keep in mind, this is around 4 o'clock. 5 o'clock comes, no CT scan. Her blood levels are continuing to drop. By this time, she's beginning to shiver uncontrollably. 6 o'clock, no CT scan. She's beginning to become pale. She's in extreme pain. 7 o'clock comes, 8 o'clock comes, no CT scan. I'm begging, I'm pleading the staff to do something. And around 9 o'clock, as I continue to plead for my wife's life, the staff at Cedars-Sinai Medical Center tells me, sir, your wife just isn't a priority right now. 8 o'clock comes, 9 o'clock, 10 o'clock. They said, well, we need to do a blood transfusion. I'm saying, well, where is the CT scan? It wasn't until after midnight that they finally took my wife back to surgery. After I begged and pleaded for them to take action for more than 10 hours. When they took Kira back to surgery, they opened her up, and there were 3.5 liters of blood in her abdomen, and she coded immediately. Now, I'm here to tell you this. I'm not here to tell you what I think. I'm here to tell you what I know. There are people on this panel that are far more intelligent than I'll ever be that are going to talk to you about the statistics and how horrifying they are. What I'm here to tell you is this, is there's no statistic that can quantify what it's like to tell an 18-month-old that his mother's never coming home. There's no matrices that can quantify what it's like to explain to a son that will never know his mother just how amazing she was. My wife deserved better. Women all over this country deserve better. I'm so grateful to my Shiro, Congresswoman Jamie Herrera Butler. Thank you so much, Congresswoman DeGette. And for those of you all who have supported this bill, I honest to goodness would love to come up there and just give you a big hug. But I've been explained that that's not protocol. And let me say this, for those that choose to stand in opposition to this bill, you don't owe me an explanation. You know an explanation to my boys. You owe Tara Hanson's son an explanation. You owe Mustafa Shabazz and his son an explanation. We have an opportunity to do something here and now to send a loud, definitive message to this country that women and babies matter. Kira and I always talked about raising men that would change the world. It's time for us to stop telling our children that they can change the world and show them how it's done. Thank you for your time.
Mr. Johnson, we do sincerely appreciate your testimony, and our as a committee, I will say we are terribly sorry for your loss, but grateful for your courage to be here today and present your testimony to us.
Thank you.
Thank you, Mr. Johnson. Ms. Stewart, you're recognized for 5 minutes.
Thank you, Mr. Chairman.
I know, it's tough to follow.
Very hard to follow that. I am known by my family to be one of the biggest crybabies, but it's for good reason. So thank you for inviting me to testify at this very important hearing today. I am Stacey Stewart. I'm president of the March of Dimes. March of Dimes is leading the fight for the health of all moms and babies. And I'd like everyone in this room to take a look at this blanket. Just about everyone that's had a child will never forget the very moment when a doctor placed a precious baby boy or baby girl into our arms, wrapped into one of these blankets. More than 700 times a year, beautiful babies are wrapped into these blankets, and one just like this one. But unfortunately, there's no mother to hold a child that's wrapped in that blanket. So that's not just a statistic. There are 700 mothers that die every single year, and over 50,000 who experience dangerous complications that could have killed them, making the U.S. the most dangerous place in the developed world to give birth. And we think, and we know that you agree, that this situation is completely unacceptable. Our nation is in the midst of a crisis in maternal and child health. Across this nation, virtually every measure of the health of pregnant women, new mothers, and infants is going in the wrong direction. The number of babies born premature is rising in this country. In many communities, rates of infant mortality exceed those in developing nations. Nations such as Slovenia and French Polynesia have better infant mortality rates than here in the United States. Women are tragically dying, women like Kira, from pregnancy-related causes and are suffering from severe health consequences like infertility. While other countries have reduced their maternal mortality rates, the number of women who die from pregnancy-related causes in the U.S. has doubled in the last 25 years. And as we've heard this morning already, Black women are 3 to 4 times more likely to die from pregnancy-related causes than white women, which is a truly shocking and appalling disparity. Maternal mortality is also significantly higher in rural areas, where obstetrical providers may not be available, and delivery in rural hospitals is associated with higher rates of postpartum hemorrhage. March of Dimes will release a report in the coming weeks that will show that maternity care deserts exist in this country, and in these deserts, pregnant women face serious challenges in receiving appropriate care. The state of maternal health in the United States is dire, but there are things we can do and we must do. Many factors are contributing to the maternal health crisis in this nation, and our work to address it is important, and it must be equally multifaceted. The bill before the subcommittee today is a critical step towards preventing death or serious health outcomes for pregnant women and new mothers. The discussion draft of H.R. 1318, the Preventing Maternal Deaths Act, would provide grants to states and tribes to help establish or improve maternal mortality review committees, or MMRCs. MMRCs are interdisciplinary groups of local experts that come together in maternal, infant, and public health to investigate the cases of maternal death, identify those system-wide factors that contributed to these deaths, and then develop recommendations that would help prevent future cases. MMRCs are unique in that they identify solutions, not just collect the data, but then identify solutions that are targeted to the needs of pregnant women and mothers in specific states, cities, and communities. The discussion draft of H.R. 1318 would also establish a demonstration project to determine how best to address disparities in maternal health outcomes. Mr. Chairman and members of the subcommittee, while this bill is extremely important, maternal mortality is not a single problem with a single solution. The causes of maternal mortality and severe maternal morbidity are diverse. They include physical health, mental health, social determinants, and much more. They can be traced back to the issues in our healthcare system, including the quality of care, as we just heard so passionately from Charles, systems problems, and of course the issue of implicit bias that exists in our healthcare system. They stem from factors in our homes, our workplaces, and our communities. Mr. Chairman and members of the subcommittee, thank you for recognizing the urgency and the magnitude of this public health crisis. Our nation's mothers and babies cannot wait any longer. We must act now to save the lives and the health of pregnant women, new mothers, and their babies. Thank you.
Thank you, Ms. Stewart. Dr. Coslet-Charlton, you're now recognized for 5 minutes, please.
Chairman Burgess, Ranking Member Green, Chairman Walden, Ranking Member Pallone, and distinguished members of the Energy and Commerce Subcommittee on Health, thank you for inviting me to speak with you today on behalf of the American College of Obstetrics and Gynecologists at this hearing entitled Better Data and Better Outcomes, Reducing Maternal Mortality in the U.S. ACOG, with a membership of more than 58,000, is the leading physician organization dedicated to advancing women's health. Today's hearing will focus on a discussion draft of H.R. 1318, the Preventing Maternal Deaths Act, sponsored by Representatives Jamie Herrera-Butler, Diana DeGette, and Ryan Costello. I want to extend a special thank you to the bill sponsors for working so diligently on this bipartisan legislation, a critical first step in improving maternal health outcomes for women in this country. Special thanks also to you, Dr. Burgess, my colleague, OBGYN, for your leadership highlighting this critically important issue and making maternal mortality a top priority. As many of you know, the United States has a maternal mortality crisis. Too many women die each year in the United States from pregnancy-related and pregnancy-associated complications. We have higher maternal mortality rates than any other developed country at a time when 157 of 183 countries in the world report decreases in maternal mortality. Ours is rising. Black women are disproportionately affected and are 3 to 4 times more likely to lose their lives than white women. And for every maternal death in the United States, there are 100 women who experience severe maternal morbidity or near misses. This is all unacceptable, and the time for action is now. We know that over 60% of maternal deaths are preventable. Common causes include hemorrhage, cardiovascular and coronary conditions, cardiomyopathy, or infection. Overdose and suicide, driven primarily by the opioid epidemic, are also emerging as the leading causes of maternal mortality in a growing number of states, including my own. If we have a clear understanding of why these deaths are occurring and what we can do to prevent them in the future, we can save women's lives. The Preventing Maternal Death Acts assist states in creating or expanding maternal mortality review committees through the Centers of Disease Control and Prevention. MMRCs are multidisciplinary groups of local experts in maternal and public health, as well as patient and community advocates that closely examine maternal death cases and identify locally relevant ways to prevent future deaths. While traditional public health surveillance using vital statistics can tell us about trends and disparities, MMRCs are the vehicle best positioned to comprehensively assess maternal deaths and identify, most importantly, opportunities for prevention. As ACOG's Pennsylvania section chair and incoming District 3 legislative chair and a practicing physician for over 20 years, addressing maternal mortality is of critical importance to me. As an OBGYN, seeing a woman die while pregnant or after delivering a baby is something that sticks with you for life and has stuck with me throughout my career. Preventing that kind of tragedy and ensuring the health and safety of the women we care for is central to our mission. When I took over as ACOG's Pennsylvania section chair, Pennsylvania did not have MMRC, though the city of Philadelphia did. And over the past 2.5 years, I have worked diligently to organize a campaign with other OBGYNs and other advocates in my state and the Department of Health to urge the state legislature to pass legislation to form our first statewide MMRC. Finally, on May 9th, Governor Wolf signed the Maternal Mortality Review Act. Our first meeting is next week. Enthusiasm like this for MMRCs is growing all over the country. Today, approximately 33 states have MMRC, and as many of those 33, including Pennsylvania, are brand new this year. But states like ours need help. The CDC plays a vital role in assisting these states to ensure their MMRCs are robust, multidisciplinary, and using standardized reporting, which is why it's important to have this federal legislation as mechanisms. The Building U.S. Capacity to Prevent Maternal Deaths Initiative, a partnership between the CDC's National Center for Chronic Disease Prevention and Health Promotion, the CDC Foundation, the Association for Maternal and Child Health Programs, and Merck for Mothers, has made tremendous progress giving technical assistance to states to help them establish MMRCs or ensure established MMRCs are operating with evidence-based practices. In Pennsylvania, we need to ensure that this type of technical assistance is amplified so that we can get our MMRC off the ground and working correctly. Once MMRCs are up and running, they lead to opportunities for quality improvement. For example, to participate in the Alliance for Innovation on Maternal Health, or AIM, a state must first have an MMRC. AIM, convened under ACOG's leadership, is a national alliance of clinicians, hospital administrations, patient safety organizations, and patient advocates that work to reduce maternal mortality and severe morbidity by creating condition-specific bundles, which are evidence-based toolkits to improve maternal outcomes. Some of these bundles include severe hypertension, maternal mental health, obstetric care for women with opioid use disorder, obstetric hemorrhage, and racial disparities in maternity care. To participate in AIM, a state must first have MMRC. The data recommendations from MMRCs instruct states where they need to invest to address specific conditions that affect women and their community and ensure proper appropriate targeting of limited resources. For us to clearly understand why women are dying from preventable maternal complications across the country and make lasting improvements, every state must have a robust MMRC. The Preventing Maternal Deaths Act will help us reach that goal and ultimately improve maternal health across this country. Thank you very much for the opportunity to speak to you about this pressing issue and in support of this very important legislation.
Thank you, Dr. Charlton. Dr. Greer-Perry, you're recognized for 5 minutes, please.
So thank you, fellow ACOG member, Dr. Burgess.
And if you'll suspend for a moment, in the interest of full disclosure, I am a dues-paying member of the American College
Here we
of
go.
Obstetricians and Gynecologists, and I am current on that.
right.
And I don't do the emeritus stuff. I pay the full freight. So you may proceed.
Great. And Ranking Member Green, thank you as well. And to my fellow colleagues on the panel, I really feel like going last is always a great way to go because you can hear what the gap might be in explaining this. I get to work with the 33 states who are doing the MMRCs. As an organization, we provide technical assistance. We also get to work in places like Philadelphia who've been doing it for a while. So a concrete example would be in Philadelphia, they had a lot of women who were dying from cardiomyopathy, which sounds really medical, right? Because your heart fails, it won't pump as well. When they actually reviewed the deaths, many of the women had heroin addiction, right? So it was something you could prevent if you actually put in mental health care services for addictions. So it's important for us to have a broader view. Someone brought up California, which is really important. So California has decreased their deaths, but they still have a racial disparity. Still in California, despite having these great outcomes, they have had increased deaths for Black women. So what they're doing now is really going back to look at implicit bias that was mentioned, making sure that their providers are culturally competent, having some rules around what does it mean if you don't value a woman and she's not seen for several hours? How does that system respond to that, and what can we do differently to ensure that people are seen in an appropriate amount of time? So just wanted to give some teeth to how important this is and how having the ability to actually look at the deaths individually and to talk to family members and to have mental health there really can help us to get to some answers. So now I want to tell you a little bit my own story. So, because every woman's story needs to be heard, and this is what the MMRC allows you to do. So when I was a third-year medical student in my home of Louisiana, after attending Princeton for undergrad, my then husband and I were expecting our planned second child. At about 5.5 months pregnant, my water broke. My mother, who's here, and a pharmacist, still recounts how panic-stricken she was when she was counseled by my physician about the risk of infection to my son and I that included death. I had access to excellent health care for him, provided by my health insurance coverage, but the stress of racism was my only risk factor for the premature birth of my son. The hospital where I was training was named Confederate Memorial just 20 years prior to this. Luckily, my 22-year-old son and I survived, but the sad reality is that my 25-year-old daughter has a higher risk of dying in childbirth than I did when I had her. The same is true for all of us who have daughters in the United States. We are failing our daughters, especially our Black daughters, who are dying at 3 to 4 times the rate of their white counterparts. So ultimately, what we're asking for this bill, when you think about what Charles said and what all of us have said, is we can no longer delay acting. This bill has been reiterated many times in Congress, and I'm excited to hear that maybe we can have it done by the end of this year, because it's important for us to say that we as a country, I got to testify at the UN about this very issue. The world is watching us. The world sees us. I get flown to Geneva to talk about how important it is for the United States to actually value women and to pay for and look at why women are dying. So this is an opportunity for us to say, yes, we do value women, and yes, we do want to see what's actually happening to them. So ultimately, what women, especially Black women in the United States, needs is accountability. We need to know that our lives are valued. We need to know that this accountability might be difficult, it might be complicated, but government still has an obligation to act. Accountability is a value that all Americans can agree upon. Yet racism, classism, and gender oppression are killing all of us, from rural to urban America. This is not about intentions. Lack of action is unintentionally killing us. It is a human rights imperative. We must ensure that prevention efforts and resources are being directed towards the areas of greatest need and be willing to name the problem directly. Much can be accomplished through improving monitoring and data collection. Me and my big writing, because my eyes are getting bad, I'm getting old. HR 1318 is a tremendous step forward in showing that we do recognize, yes, Black mamas matter. And that is it.
Thank you, Dr. Perry, Dr. Career-Perry. I appreciate your testimony, appreciate all of our witnesses for being here. We'll move to the question part of the hearing, and I'll recognize myself 5 minutes for questions. And Dr. Charlton, let me ask you we've heard the stories, and yes, the review committees are important, legislation is important, but honestly, doctor to doctor, it's the decisions that are made at the bedside. And I honestly don't know how you legislate correct decisions to be made at the bedside. So as part of this effort, and as a fellow member in the American College of OB-GYN, it's really incumbent upon our professional societies, our medical societies, our specialty society. I mean, this is where the rubber meets the road. We have to be, I don't know how I can legislate something that stops what Mr. Johnson went through. I just don't know how I can do that. I mean, here was a situation where all the signs and symptoms pointed to exsanguination. And he describes, unfortunately, in very painful detail what the natural consequence of exsanguination is. And I don't know how I write legislation to stop that from happening. I mean, that's on us as a profession, right?
Totally agreed. And I think that's why we're here, and that's why we're sitting beside Mr. Johnson, because those stories, I think, affect, and I know, Dr. Burgess, because you practiced for so long, I look at my intern year. I was on my internal medicine critical care rotation, probably the second month of rotation, and I was called for a code for a woman who had a very rare condition called an amniotic fluid embolism, which I don't know if you've seen one in your career, but I was like, what could this be? 1 in 300,000. And she died in front of me. As an intern observing, I wasn't actively participating in the care at that time. But I seriously questioned whether or not I wanted to go into this field at that time because, and I'm so glad I did, because the joy of being an OBGYN far outweighs the unfortunate things that happen to patients sometimes. But I think seeing that if we can prevent one death, if we can educate our members, and really the best way to do that is to understand where the problems lie. And the AIM programs are a great success story. And if we're able to roll them out across the country and really see where we can use best practices to prevent things from happening that couldn't otherwise. And really, obstetric hemorrhage is a perfect example. We're having, the beauty of the AIM program is that it's really, readiness first, so the 4 R's, readiness, and then recognize that there's a problem. So the readiness includes things like having suture available, having medication available on the labor floors, that you're not calling a pharmacist to come, I need this medicine now, not an hour from now while you approve it. So being ready, being able to recognize that there's a problem, and educating staff members, not just physicians, but also people that are on the front lines caring for the patients first. And also the response, and having protocols for response that are appropriate, having blood products readily available for women when they're in transfusion protocols we've shown to be effective. And finally, reporting, because when we talk about maternal mortality and we talk about the deaths, that's very important, but also the near misses are equally devastating and equally important that we know how to identify them. And not only, we're seeing the iceberg, if we can really get to the crux of that, we're truly going to improve the way we care for women in this country. And I'm positive we're going to see less maternal deaths.
Well, and that's what's critical about this. Maternal mortality review committees, I think that's an excellent idea. I'm all in favor of that. I will just say, in the 1970s at Parkland Hospital, it was called Grand Rounds, and you didn't ever want to present at Grand Rounds. That was probably meant your patient hadn't done well, but what it really meant was you weren't going to do well for the next couple of hours. Right. And Dr. Jack Pritchard was the head of the department back then. He was pretty critical and had a way of asking those insightful questions that exposed any perhaps weakness in your clinical judgment or your thought process as you work through a complicated issue. let me just ask you, I mean, have we gotten away as a profession from that type of introspection that you probably were exposed to in residency, and I know I was?
No, I think if you speak to any residents, those processes still happen, but they happen mainly in academic centers. And, you know, really part of this problem is that we've got to better reach the communities. I practice in a small community hospital right now, and it's very different.
Yes, did I?
You know, I think and educating practitioners in the community hospitals we know is equally as important. And, you know, and access to care, obviously, as we've spoken to, is equally important. So I think being able to collect the data, being able to see where the deficiencies, and having a mechanism and a vehicle and support, you know, nationally down to the state levels and the tentacles that can get, you know, the boots on the ground to make sure that none of these things happen anywhere in the United States. It's critical.
Well, Mr. Green gets extremely critical of me if I run over, so I'll yield back my time and recognize the gentleman from Texas for 5 minutes for questions.
Time, Mr. Chair. I'm going to thank all our witnesses. And Mr. Johnson, being a father of 2 children and now a grandfather, I just, you know, as the chair said, I don't think there's anything we can do. Of course, there's no shortage. We have a lot of doctors in Congress, but we also have a lot of lawyers. And so people say, well, you can go to the tort system. But that's not going to bring back your life or your wife or your second baby. And it's just, you know, how do you do that? So, but we understand, those of us who have children, and I know physicians particularly. So I'm going to thank all our witnesses today being here and discussing the U.S.'s maternal mortality rate, which I would be remiss if I didn't acknowledge my home state's maternal mortality crisis as well. As widely reported in 2016, published in Obstetrics and Gynecology, found the Texas maternal rate was doubled between 2010 and 2012. The study's authors acknowledge these statistics were unexplainably high. In the wake of this report, Texas Maternal Mortality and Morbidity Task Force underwent review of all pregnancy-related deaths in Texas to determine the accuracy of these findings. What the task force found was that data collection errors and lack of standardization in reporting has resulted in varying statistics. If we can't depend on the research, that's a problem. Dr. Charlton, can you explain why the standardization of data collection is so critical when discussing maternal death rates?
That's a very important question, Representative Green. And I think the crux of the issue is that the vehicles of looking at vital statistic records were able, in the maternity check boxes of someone pregnant within a year or 42 days in Texas of delivery, that those measures certainly can identify and are inherent to error. But the important thing, and why we're here today, is to make sure that all of those deaths are reviewed so that we can have accurate data. And that's why these maternal mortality review committees are essential, because not only are they going to review the deaths, but they're going to be able to say, you know, determine if they could have been preventable deaths, and that's where the impact truly could be made.
What can we learn from this study in Texas? And tell me, Texas is not the only state that has that kind of statistics that you can't depend on. Is it in other states, in Pennsylvania, or other states in the country?
Well, in Pennsylvania, we've had the checkbox for the past 5 years, and I think that in Philadelphia, there's been a small community. They've been able to focus on that data, but I think that, like I was saying, the essential part of this is that having accurate data is really, really, truly important, and the Texas studies truly exemplify that, how important these MMRCs are. The Texas committee at that time was not as sophisticated as it is now, and their means of collecting aren't as sophisticated, so I think that going forward, it's a perfect example of why this is essential.
The Texas Maternal and Mortality and Morbidity Task Force put out a series of recommendations on the ways to improve the maternal health and prevent pregnancy-related complications. Just as last month, the task force released its joint biannual report for our Department of State Health Services. Their first recommendation is we increase access to health care services to improve the health of women, facilitate continuity of care, and enable an effective care transitions and promote safe birth spacing. Dr. Perry, would you agree with the recommendation to improve maternal health? We must improve the access to care.
For sure, and I want to also piggyback on the last question a little bit about the data, because it's important that we it is a common phenomenon across the country, so it's not just Texas, and it's not just Pennsylvania. A lot of states need this money to help with collect more accurate data. It would be really helpful. And as far as access, it's a big barrier. We see that places where we're closing rural hospitals in Texas, in Georgia, that when women have to travel an hour to have a baby, they're more likely to hemorrhage. They're more likely to have a heart attack. They're more likely to have these medical conditions. So if you don't have a systemic review, you can't look at the match between where your access is being denied and where women are also dying in the same place. So having a more robust review of the deaths will allow you to look at that.
From my perspective, coming from Texas, one way to improve access to care is expanding access to Medicaid and ensuring low-income individuals have the care that they need. And do you agree with that?
Sure. I mean, I'm from the great state of Louisiana, and so we've seen actual data since Louisiana and expanded Medicaid. We're one of the few deep southern states that expanded Medicaid where we've had improved outcomes. Our governor really was important for him to ensure that we had access to Medicaid expansion. Women are getting preventative services, so you know that you have diabetes before you become pregnant. You don't show up at the hospital pregnant and with uncontrolled blood sugars. So it's important that we have expansion of Medicaid.
And in my last 9 seconds, there is no replacement for prenatal care. And having a mother who has a relationship with their doctor. And that's why we need to have that access no matter who pays for it, Medicare, private sector, or whatever. So, Mr. Chairman, thank you for your time.
Chair thanks, gentleman. Gentleman yields back. Chair recognizes the gentleman from Kentucky. Mr. Guthrie, the Vice Chairman of the committee, 5 minutes for questions.
Thank you, Mr. Chairman, and I appreciate everybody being here. Mr. Johnson, appreciate you coming here and be willing to share your story. I know that a lot of times we have policy develops and things develop because people went through tragic things and they're willing to bring that to our attention and share. And I know it's difficult to do, but it's one way that they live on, and it's a way that it actually changes what's going on in the country. So I appreciate that. And it's something that's been on the mind of the committee. I know the chairman, I know from his background, but also I remember being in a meeting earlier, and we're trying to just get down to the policy that needs to happen. And your story, I remember one of the roundtables that the chairman has talking about it's not just access to care. You sound like your wife was in a fantastic hospital situation, everything, and it seems C-sections were something that could be common, and we are the most. It's not that people aren't getting care; a lot of people are getting C-sections, and my wife's I have 3 children, we've had 3, so it really made me cringe when I heard that in your story, because it seems the second or third or whatever C-section seemed to be something that is something we need to address in moving forward. And that gets to just finding the right data. And Dr. Carlton, I was, I know you're here with ACOG, and in this bill today, we're looking at data and how to move data. I know ACOG has endorsed a number of medical societies and ACOG's endorsed this bill, and it's my hope that we can get sound data to see exactly the actions that we need to take. So can you speak to ACOG's perspective on the role of data in your efforts to reduce maternal mortality?
So I think to some degree when you're speaking about specific situations like C-section rates and talking about, once a woman has a first C-section, second C-section, third C-section, we know each time that a woman has C-section, risk can increase with subsequent pregnancies. And those are important reasons why, number one, we need access to good care. But also the part of the AIM bundles where we talk about preparedness or readiness is that when we know a woman has a third C-section, knowing that if she has the ability to have important prenatal care to recognize potential complications and be ready for those complications, that's critical and essential. And the last thing, if we talk about the AIM bundles, one of the bundles is looking at how to improve primary cesarean section rates. So that's something that's good data that's coming out of California that we hope can translate. Sharing data across state lines. Women are women. In Pennsylvania, the same as in Arizona. So it really isn't rocket science. We should be able to share data and establish best practices. And the way to do that is to have the vehicle or the mechanism to accurately be able to identify and look through that data.
It just seems standard, not being a physician at all. I'm a manufacturing person background. It just seems to be standard now that if somebody's having their second or third C-section, that the symptoms your wife showed seems to be clear from what you've said, that maybe there should be a team waiting to see if something happens and being ready for any type of those complications. You said you wanted to comment.
Absolutely. I think that the astronomical C-section rates are something that needs to be examined. When we talk about Kira's case, there was a C-section indeed, but it wasn't the C-section that led to her ultimate passing. And I'll share this with the committee, and I didn't share. What I shared earlier was a very condensed version of what has happened to Kira. But what we found subsequently when we go back and look at the medical records, which I shared as part of my record, is that in Kira's case, she was exceptionally healthy. She went in for a routine scheduled C-section. And from what I understand, and Dr. Burgess and some of the medical people here, so what I understand is that for a woman who's having a cesarean section, the cut time, meaning the time that they make the incision to the time that the baby is born, for a healthy woman that the baby is not in distress, should be between 12, 15 minutes. Is that fair, Dr. Burgess? Okay. In a situation where a woman has had a previous cesarean, you should add another 3 to 5 minutes so that you can cut around the scar tissue.
The problem is the scar tissue in the second, third. Dr. Burgess explained that to me.
Yeah, so I'm gonna, so this is the point I'd like to make, is, so we're talking about between 15 to 20 minutes, ballpark, for a woman that's healthy, second cesarean section, the baby's not in distress. When we received the medical records from Cedars-Sinai Hospital, the cut time on the delivery for my second son, Langston, was less than 2 minutes. Less than 2 minutes. And in the process of him rushing, he lacerated her bladder. But once again, and so the way that this has been described is that this was not a medical tragedy, this was a medical catastrophe, meaning that everything that could have gone wrong did go wrong. So let's talk a little bit about AIM, which is a phenomenal program, and I want to salute ACOG for the work that they're doing in conjunction with AIM and being rolled out in various states. California, where my son was delivered, is one of the trademark states for AIM and what they've done to reduce the maternal mortality rate with their hemorrhage bundle. But as long as we have these tools that are a suggestion and they're not a protocol, women are going to continue to pass away. So the AIM bundle was available in Kira's case. It's it's ground zero for the wonderful work they've done in reducing the maternal mortality rate in California, but they just chose to ignore it. And I continued to beg and plead while her condition deteriorated. So cesareans are a challenge, but in Kira's she was extremely healthy, and they just let her continue to deteriorate. So we've got to have a fundamental standard of care that's not just a suggestion as AIM as it is in the situation with AIM, and it's phenomenal. But if we can make a fundamental standard of care across the board, that'll make a big difference.
Thank you. Thank you for sharing, and my time's expired. I yield back.
Thank you, Mr. Guthrie. Mr. Cardenas, you're recognized for 5 minutes, please, for questions.
Thank you very much, and to Mr. Johnson, it's just amazing and incredible that you're doing what you're doing, and thank you so much. You're saving lives, and I appreciate that very much, and so does everybody in this country and in the world who will benefit from hopefully good decisions that we make from all of your efforts. First, I'd like to ask some questions of the doctors, but I recently read about a program in California that has been very successful since both the March of Dimes and American College of Obstetricians and Gynecologists are part of the California Maternal Quality Care Collaborative. I'm hoping that both Dr. Coslett-Charleston and Ms. Stewart can tell us more about this program. But in California's private-public partnership, they've stressed that it was because of the views from a diverse panel of experts that they could avoid missing important details on women's deaths. And one of the things that I think is important for us to understand is I've been given a chart about the red line shows the mortality rate across the country, while the highlighted yellow line actually shows California's. And we see a dramatic drop since 2007 when California has implemented the process of teaching each other, learning from each other, sharing data. And you're looking at California that has a mortality rate of 7.3 per 100,000, and across the country it's still up at 22. So what I'd like to see happen is we as Congress and those of us who are involved, or those of you who are involved on the day-to-day process, that we can come together and create a national best practices, and I hope that that's the outcome not only of this hearing but of this Congress. Dr. Coslet Charleston and Ms. Stewart, if you can you talk a bit about how the diversity of these panels has changed and improved the maternal outcomes?
Well, let me just start with a couple of points, which is I think that it's notable that California has had so much success, obviously, and I think the idea of the committee that's been formed, the way they've come together to look at data, to design interventions, identify where the problems are within the state, and really design interventions that have made a meaningful difference has been important. And that's important to say at a high level, but again, when it comes down to each individual person who still may be affected by the gaps in the system, like Charles and like his wife, Kira, then we still have a problem. I want to say one thing about diversity in general and the importance of how this issue shows up and the disparate outcomes that many women of color experience as a result of the gaps in the system. And I agree with the chairman, we can't legislate morality, but what we can do is ensure that we are tracking the performance of the system, we're tracking those women that are impacted disproportionately by the system, and that we are intentional in designing interventions that will make a difference. The gaps in the system don't just start, though, when women show up in the hospital. They start well before that. We know that, for example, to make sure that we have healthier babies, it doesn't just happen in the 9 months of pregnancy. And I'm not a physician, I'm not an OBGYN, but I think I've known that in my own experience, having had two babies and leading the March of Dimes, which is the leading organization in the fight for the health of moms and babies. The same is true for healthier mothers. We've got to make sure that women have access to health care before they're pregnant, especially if they have chronic diseases, chronic health challenges that might risk their health or the health of the baby. We've got to make sure they have access to good, affordable care during pregnancy. And what we know now is that's important that women have access to excellent care after. And it's especially important, and we have had research and studies to show that women of color often feel less trust in, and less well served by the system. They feel less listened to and respected in terms of their symptoms when they articulate those symptoms. And these are women that are not only low-income women of color, these are women that are affluent women of color, women that are highly educated, who simply have reported, and again, studies show this, that their needs are not being met at the same level, at the same rate as white women and other women. So I just want to say that I think this issue of diversity is really important, not just in the panels, but across the board, and listening to the issues of disparate outcomes that we see across all communities.
So best practices are something that we can improve, and hopefully we become more prolific so we can have the outcomes that you just described. My time is limited, but hopefully during the testimony, some of you could talk about the toolkits and how these toolkits are free. But a quick question to Mr. Johnson is, since you've lost Kira, it's been 2 years, how has this affected you and your family? If you could describe that for us so that we can understand the true responsibility that we have, and we can make sure that this happens less and less and less. Thank you.
Well, you know, this has been the most challenging experience that I've even more challenging than anything that I could ever comprehend. That being said, the true blessing in all of this is the two tremendous gifts that Kira left us, and that's my son Charles and my son Langston. And they really truly are what keeps myself, my mother who's seated behind me, all of us going. And you know, it's difficult as they mature and as they're, you know, now 2 and just turned 4 years old. Their ability to process and understand the absence of their mother evolves. And like I said, you know, when we talk to a 2-year-old, he wants to know why his mommy's not coming home. And you explain to him, well, your mother's in heaven and she's doing important work with God. And he tells you, well, I want to go to heaven too. And so there's nothing that I can prepare for. There's nothing that I can do to fix that. And I hope that over time that, you know, their hearts are, and to just be completely honest with you, is I'm proud to be here representing these families But at the end of the day, I'm just a father whose heart aches for his sons, and husband that misses his wife desperately. And so while every day I search for answers and how to support these amazing gifts, what I am clear about is that what I have to do is, although there's nothing I can do to bring Kira back, I have to do everything that I can, whenever I can, to make sure that I send other mothers home with their babies. And that if I can prevent another father from going through this, if I can prevent another child from having to understand why his mother isn't showing up at school, and I'll share this with the committee, and it's something that I've never been shared with my family, is when a 3-year-old asks you, "Daddy, is mommy mad at me? I want mommy to come home. Why won't she come home?" And I've never shared that with anybody because it's just too painful for me to articulate. But I'm clear that the work that we're doing here is going to prevent, and it's going to prevent this to continue to happen to other women, and it's going to make sure that other women get to go home with their babies.
Mr. Chairman, if you allow me a few seconds to thank Mr. Johnson. My time has expired. Thank you so much. Thank you for your courage, your strength, and your commitment to community and to others. And God bless you and your family. And know that your wife is doing good work in heaven, but you are doing tremendous work on earth. Thank you. I yield back.
Chair, thanks, gentlemen. The gentleman from California referenced the California Toolkit to Transform Maternity Care. I did print off a copy of that, and at the conclusion of the hearing, I will ask unanimous consent to make that as part of the record. Chair now recognizes the gentleman from Ohio, Mr. Lotta. 5 minutes for your questions, please.
Well, thank you very much, Mr. Chairman, and thanks so much for our panel of witnesses for being with us today, because it is so important for the work that you're doing and getting this message out. Ms. Stewart, if I could start my questioning, I'm also concerned for soon-to-be mothers and new moms that live in our rural areas of our country. And the national data indicates that more than half of all rural U.S. counties are without hospital obstetric services. With an increase of women dying due to pregnancy-related complications, how does access to care and hospital services affect pregnancies and postpartum recovery? And is this issue exacerbated for women in our rural communities?
Thank you very much. It is a very serious issue, and thank you for the question. And as I mentioned in my statement earlier, the March Times is working currently on a report that would really show this issue of maternity care deserts. The issue of the closing of community hospitals in rural areas has been well documented. I think one of the things that we're missing is that it's not just the closing of hospitals, it's the closing of hospitals compounded by the lack of obstetrical services and OBGYNs, the lack of midwives and doulas in areas, the distance that women often have to travel just to receive care. And it's particularly acute, not just in rural areas, there's a major challenge, but one of the things we're looking at is even where in urban areas there can be maternity care deserts as well. I'll give you a good example of this. Here in the District of Columbia, there is no hospital that provides obstetrical services east of the river in wards 7 and 8, so east of the Anacostia River. Tens of thousands of women who live there who have no hospital to go to, who then have to travel. If they have no transportation, they have to go on the metro, often an hour or more, to even go to a prenatal visit. If you're a high-risk pregnancy or you have a high-risk pregnancy, the complications that are then exacerbated, or the complications that can result because of that distance, because of that lack of access, is increased significantly. So one of the things that we need to really talk about in the system is the fact that even in the District of Columbia, for example, where there may be the number of beds may be sufficient for the number of women, that doesn't mean that those beds or that care is available to all the women that need it when they need it. And that's a very significant problem. So I think one of the things that we're doing in the March of Dimes is to try to work with our friends in healthcare, our partners. ACOG has been a long-time partner of ours, working with hospitals and others to make sure that services are available. The last thing I'll just mention is that because all these issues that we're talking about today really disproportionately, again, impact women of color. Women of color, African-American women, are 3 to 4 times more likely to die as a result of childbirth. We also need to look at other ways in which services can be provided. We know that African-American women, for example, are far more likely to receive services and care from a doula, working within the formal healthcare system. And we've got to make sure that those services are also available so that women have places they can go, they can trust. They know they go to places that will listen to them and that will respond to their needs and that will deal with their situation if they have high-risk needs as well. And what we're seeing today is that there are significant gaps in rural areas as well as in urban areas, too.
Well, thank you. Dr. Coslett, Charlton, our country's facing an opioid epidemic, and especially in the state of Ohio, we're unfortunately about the 3rd worst in the country. And while Congress, and especially this committee, has done a lot of work, and we've passed a lot of bills trying to reverse this devastation, I can't help but think of the pregnant women and the new mothers who struggle with addiction. And how prevalent is opioid abuse in maternal deaths?
Well, I would comment that it is very significant, and that's why it's so important that these maternal mortality review committees include diverse members, including mental health professionals, substance abuse professionals. And I know when we established our panel in Pennsylvania, it was imperative that we had representatives from communities because that is a very significant issue. And I know Philadelphia has seen a large increase, that they've done a good job at looking at their data, almost a doubling of maternal deaths over a short period of time related directly to the opioid abuse process. And, you know, ACOG really appreciates all of the work that government's doing to make sure that pregnant women are a special population that sometimes have different needs. So the pregnant addicted mother, number one, it's a great population to invest in, because women that are pregnant that have opioid use disorders are often motivated to get better. You have a reason to get better. I mean, not that everybody doesn't, but a pregnant woman is a special population. And the other thing that we've seen is that doing not only paying attention to different prescribing needs of women as we're limiting prescriptions, I see in my state, things like that, to make the special considerations for pregnant women that may have difficulties with access and need, and to make sure that they continue on treatment during pregnancy and postpartum. The last thing is that there's special pilot projects that are coming out of these committees looking at the special population of pregnant women in like soft landing centers where we're not separating moms and babies, and very importantly, not making punitive decisions based on maternal care, and that because we know that women that fear losing their child or going into a system are not going to seek prenatal care, and how imperative that is for the health of the woman and the child that she's carrying. So those are all things that ACOG is working very passionately on to try to improve the health care of women related to opioid abuse disorder.
Well, thank you very much, Mr. Chairman. My time's expired, and I yield back.
Chair, thanks, gentleman. Gentleman yields back. Chair recognizes the gentlelady from Colorado, Ms. DeGette, 5 minutes.
Thank you so much, Mr. Chairman. And I want to thank all of our witnesses, but especially you, Mr. Johnson. I just can't even imagine what it must be like raising those 2 boys. And I'm glad your mom is here to help you, but you know, I want to come over and help myself, but I'm not sure and I think probably most of us feel that way. If there's anything we can do, I think the first thing we can do is pass this bill. And I've been working with my co-sponsor, Representative Herrera Butler, to try to get this bill passed by the end of the year. And I think your testimony is what will bring us over the line. So if, you know, people wonder, does it make a difference? That answer would be yes. So thank you. I want to ask you, am I pronouncing it correctly? Creer-Perry? Creer-Perry, okay. I want to ask you, Doctor, according to the CDC, the nation's maternal mortality rate rose by 26% between 2000 and 2014. Is that correct?
Yes.
One of the most striking aspects that I've been researching of this uptick is that African American women are nearly 4 times as likely to experience a pregnancy-related death than other women. Is that right?
It is. In some places, it's higher.
It's higher in some
Yeah,
places?
New York City, it was 12 to 1.
Wow. And can you explain to me why this is? But it goes across
It does.
socioeconomic lines, which is stunning. Can you explain a little bit about that for me?
Well, and I think for me, Charles's story really reflects this idea, right? Like, in general, in the United States, we've not really grasped the idea that women, when they're pregnant, are special populations, and it's important that we value them. So to have someone in the hospital for a long time without evaluating them, that means there's a fundamental lack of valuing them as a person and wanting to come and check on them and saying, she's not a priority right now. And what we don't do when we just look individually at the doctor, it wasn't just the doctor. So a lawsuit, when you have an entire system and a structure.
It's the whole hospital.
It's the whole structure. So how do we get to a space where Black women and women in general, right? Because the reason that the gap is high in New York and not in Texas is because white women in Texas are dying. So it's not so much that Black women are doing so great in Texas. So in general, across this country,
fewer of them.
right? Exactly. Yeah. So across this country, we don't value women. We don't have paid leave. We got to go back to work really quickly. We don't have childcare. So all those things impact our ability to have a healthy pregnancy. So how we then get into the hospital, need to rush out, or if someone is doing a fast, something quickly, it makes it more difficult for us to live. So that happens really acutely for women of color. And so you see that impact of implicit bias. So what you can legislate is rules around training on implicit bias. What you can legislate is accountability for the entire system to look at every death and make sure that all the structures that they need to have in place are put there. So it's not just one individual nurse or doctor, but it's the entire structure.
Yeah. And Ms. Stewart, many nations have actually been able to cut the rate of maternal mortality in half. I talked about that in my opening statement. I wonder if you can give us some ways that they've been able to do that we could model our own behavior on in the U.S.
Well, and in many of those countries, Congresswoman, all of the outcomes relative to moms and babies are far better than they are here in the U.S. So one of the things about what's going on here in the United States is we're focusing on maternal mortality today, as we should, and maternal morbidity, as we should. But if you look at all the outcomes around moms and babies, whether it's around premature birth, infant mortality, our outcomes are far worse than most other developed countries in the world.
And many underdeveloped countries.
And many underdeveloped emerging countries. I mentioned in my opening statement, our maternal mortality rates are worse than even countries like Slovenia.
So what are some of the things these countries have done?
So I think I think it starts at the highest level of a policy environment and an environment in general that respects and cares for and prioritizes women and women's health and women and babies. So when you look at certain countries, Scandinavian countries, for example, there are a range of policies that are far more supportive of women having a healthier lifestyle before being pregnant, having healthier pregnancies, and then having the kind of support even after pregnancy to make sure that they recover from their pregnancies well, that they feel supported, that they don't feel overwhelmed. And we know the issues of stress in this country. Chronic stress, for example, can have a devastating impact on the health of women and the health of moms that impact not only them but their babies as well. So I think it starts with making sure that women have the health care coverage that they need, have access to the care they need. We've talked about that. Half of the pregnancies in this country are covered by Medicaid. We need to make sure that all women have the kind of coverage they need. We need to make sure there are services in their communities that are accessible, as we mentioned earlier, around the deserts that exist. And then I think we need to make sure that postpartum Medicaid doesn't stop within 60 days of delivering the baby, that it extends so that moms have the kind of care and health care support that they need, even as they recover from their pregnancies.
Thank you. Thank you so much. I yield back, Mr. Chairman. Thanks to all of you.
Chair, thanks, the gentlelady. Chair recognizes the gentleman from Virginia. Mr. Griffith, 5 minutes for your questions, please.
Thank you very much, Mr. Chairman, and thank our panelists for being here. And Mr. Johnson, I'm just so sorry, and nobody should have to go through that. And of course, I'm sitting there while you're testifying thinking about my wife and her C-section with my first son. So I'm very, very sorry. And as Ms. DeGette said, if there's anything that we can do, I'm sure we would try, including passing this bill. So here's a question for you all. I like the bill. And I like the bill because it will have us looking at it from a national perspective. If we just do it on a state perspective, it may not work, because I represent the corner of Virginia that's South Side, Appalachia, and the Allegheny Highlands. And so, I border 4 states. The Bristol Herald Courier did a series of articles last year on neonatal abstinence syndrome, because we have a high number at the hospital in Tennessee. But those are my constituents, even though they're going to a hospital in Tennessee. I believe that hospital serves at least 3 states. And so if you're only looking at it from a state perspective, Virginia's going to look a whole lot better on substance abuse and other things than Ohio. But if you compare Ohio just with my section of the state, we're probably in pretty good similarity. We're in sync along with West Virginia because we have similar problems and similar backgrounds. And I've got to have some of the deserts on your map because I have an area that 2 of my counties have lost their hospitals. And so, you know, I want to see this data from a regional perspective, not just a state perspective, because my part of Virginia is not like Arlington or even Virginia Beach or Richmond. It's completely different. And if you're just looking at it from a state perspective, you get a skewed picture for my region. So I like the bill. So then the questions become, you know, do we overload the bill? And you don't want to do that. Sometimes you can put too much on it. Do we overload it by trying to include prenatal and neonatal care into the study? If we don't, and if Ms. Butler's in agreement, I'd say expand it. If it's going to overload it and we might not going to get it passed by the end of the year, let's get this one passed and do something else. But how, Ms. Stewart, how do we fix it? I mean, I'm a big advocate of telemedicine. Obviously, you can't deliver the baby by telemedicine, but maybe some prenatal or pre-birth care, some neonatal care could be done that way. What do you think of that?
Actually, we think the prospects of telemedicine, especially for prenatal care, can be very exciting and very productive. There have been several studies to show that women in rural areas, in urban areas, low-income women, are very comfortable actually receiving care. And we also know that in the postpartum, we've got some programs going on right now in the postpartum stages, where uploading data, checking, taking blood pressure at home, uploading that data has actually reduced maternal deaths significantly in places like Philadelphia and can do the same in rural areas. So we think the aspect of telemedicine in this space can be extremely helpful to overcome some of the gaps and barriers that we have. You know, I will say that we for sure believe very strongly that this area and the period of time postpartum is the most critical period that for this bill and for these issues that we're talking about. So whatever we can do to make sure that women have the care they need during that period, we're measuring maternal deaths up to a year. So we need to make sure that women have the support they need after the baby. We are, rightfully so, and we still need to focus prenatal, but what we're talking about now is the care postpartum that is now so critical and is contributing to so many of these deaths. So thank you for raising these issues.
Thank you all for being here. You know, I think as technology moves forward, we may have different answers, but I do think we have to embrace everything we can for those areas that are underserved or have deserts, as you call it. And I appreciate you all being here. Thank you all so much for what you do, and I yield back.
Chair, thanks, gentlemen. Gentleman yields back. Chair recognizes the gentlelady from Florida, Ms. Castor. 5 minutes for questions, please.
Well, thank you, Mr. Chairman, for holding this very important hearing on maternal mortality. And I really want to thank my colleague, Diana DeGette, and Congresswoman Herrera-Butler for their work on the Preventing Maternal Deaths Act. And thank you to all of the witnesses who, you all have devoted your careers to this. And Mr. Johnson, I take your story to heart, especially. This is a long overdue hearing. And I do hope that this is just a start on an important focus on policy regarding maternal health, because I don't believe that most people in the United States of America today understand that we're not doing so well, that women in the United States are more likely to die from childbirth or pregnancy-related causes than women in other parts of the developed world. That's not acceptable, and the racial disparities are particularly disturbing. In Florida, we have our Pregnancy-Associated Mortality Review Committee. In Tampa, we're home to at the University of South Florida, the Lawton and Rhea Childs Center for Healthy Mothers and Babies, and I have some wonderful experts there who help me. They have shared with me the latest Florida pregnancy-related mortality rates. Since 1999, Florida's pregnancy-related mortality rate has been flat, with no significant trend. How can that be, that since 1999 things have not gotten better? I think that's outrageous. The committee found that hemorrhage-related deaths are the leading cause of pregnancy-related deaths in Florida by far. And of course we know that more than half of these deaths are preventable. Florida's most recent review committee has the statistics for 2016. They've identified 157 pregnancy-associated deaths. 21 died during the postpartum period. That has been the focus of many of your remarks. Dr. Kozlik-Carlton, I understand in May that ACOG released a number of recommendations on ways to optimize postpartum care for mothers, including that new moms should have contact with their OBGYN or other obstetric care provider within 3 weeks postpartum and a comprehensive postpartum visit no later than 12 weeks after birth. Why is focusing on that 4th trimester or postpartum period important for the health of new moms, and what are the barriers? We've talked a little bit about it, but let's go into greater detail. What are the barriers that you and your colleagues see to prioritizing the 4th trimester? Transportation, childcare? Give us a little update on that.
So that is a wonderful question, and that is one of the exciting things that ACOG has developed, like you said, over the past several months, is reevaluating the 4th trimester or postpartum care. And we know that when we look at preventable deaths, that about half of those preventable deaths occur within that year within delivery. So it's really important that we continue to engage patients on the importance of postpartum care and also reduce those barriers that you're discussing. Number one being access. Number two being, in Pennsylvania, I'm fortunate to practice in a state and I did residency, medical school, and practice in Pennsylvania. And in Pennsylvania, when you're pregnant, you're covered. And I cannot imagine a woman not being covered during pregnancy. But that coverage for Medicaid patients ends at 6 weeks postpartum. And we know that things can happen afterwards. And it's just not, it isn't just the issues with, I've had plenty of women have preeclampsia or hypertensive disorders that need very close follow-up. I have seen women seize 6 weeks after delivery in the emergency room related to preeclampsia. So those identification of patients that are at risk, number one. Number two, having important communications in manners such as telemedicine within the first several weeks after delivery, and especially in high-risk patients, is critical. And also, we talk a lot about postpartum depression and mental health disorders and how important it is that we screen women adequately and continue screening and keeping them within that period, and also educating patients of the importance of the postpartum period. And we think that that might come during the prenatal period, and that we need to do work to emphasize the importance of postpartum care to women when they're having their babies, because I'm a mother of 4 children. I don't think I'm embarrassed to say, I don't know if I went back for a postpartum visit. I know I'm an obstetrician. I know that, are privy to knowing the signs, but I was caring for children and having important maternal and parental leave is very important, having transportation. So there's so many policy things that are exciting and that we're going forward. Hopefully we can look to all of you to make those favorable changes a reality.
One of the major gaps I see in my state and other states, Florida is one of, in the minority of states that did not expand Medicaid. And I worry about the continuity of care for young families, for young women especially, if they're not taking care of themselves early on and then they reach a gap after they have their baby. Has Medicaid been expanded long enough for there to be any studies on the differences on maternal mortality in states that have expanded Medicaids and states that have not? Do you all know?
I know it's studied it for health in general, but not specifically maternal mortality, and that's why this bill will be really helpful for us to be able to drill down on more details on maternal mortality. Yeah.
Thank you very much. And I yield back.
Gentlelady yields back. The gentleman from Missouri, Mr. Long, is recognized for 5 minutes.
Thank you, Mr. Chairman. And I've heard a lot of testimony over my years on the committee here, and Mr. Johnson, I don't know that I've ever heard any more heartfelt or any more important testimony than what we heard from you here today. So thank you for being here, and I know it's hard to do, and but hopefully your voice will add a voice and will garner more attention to this, so thank you for being here. Quick question for you. Your first son, was that, I understand that was a C-section also?
Yes, sir, that was a C-section.
Was that a planned C-section like this one or emergency?
No, that was not. So that was an emergency C-section.
Yeah.
So he went in for what we expected. And so that was part of the reason that the C-section was recommended during the delivery of Langston, our second son.
Okay. 'Cause I'm curious, but yeah, I'm a little familiar with the emergency part of that situation, so yeah. Ms. Stewart, I just want to thank you for what you do at March of Dimes and the big event you hold every year here in Washington, D.C., the cook-off, I call it. What's the official name of it?
It's called Gourmet Gala.
That's what I was going to say if you hadn't interrupted me.
It's a lot of good food there.
Gourmet Gala.
Gourmet
It's
Gala.
a dandy, and it raises a lot of money every year for March of Dimes, and
Absolutely.
appreciate that.
And we appreciate all of your support for that. Thank you.
Greatly, yeah. Dr. Coslett-Charlton, as you note, only 33 states have a maternal mortality review committee, many of which are newly created. Could you talk about the important role the Centers for Disease Control and Prevention is giving technical assistance to states to either help them establish MMRCs or ensure that they are operating effectively and getting appropriate data?
I'd be happy to speak of that. As a state that has a very newly formed committee, I mentioned earlier that our MMRC is meeting for the first time at the end of October, and I'm very excited to see the outcomes of our getting together and be able to collect this data effectively. The CDC Foundation has actually reached out to us and has been integral in not only determining the makeup of the committee and working well with our Department of Health, the members on the committee, but also ensuring, again, standardization and by knowing best practices from other states. So having that cooperation is essential. The other thing is that through the CDC, there is data collecting tools, the Maria collecting tool, which will standardize the reporting part of the MMRCs so that we're able, if the reports are looking different from every state, it's a difficult task to try to come to a consensus. So we keep talking about the importance of making sure that we keep standardization, and the support through the CDC with the Maria application is an excellent example of that.
Okay, in your testimony, you discussed Pennsylvania's efforts to establish MMRC this year. What's been your experience so far in getting it up and running?
Well, fortunately, we have an extremely supportive Department of Health for this issue, and some of it has been, similar to our efforts here, is recognizing that there's a problem, and some of the national attention to the problem has really given some interest to members that have been very interested in participating in this bill. Our bill was supported unanimously, House, Senate, and by the governor's office, so this was an easy ask. At this time, but it was more momentum, initiative, and a lot of the reports coming out that this truly is a problem that opened the eyes of many, and we realized that we need to tackle this. And it's not a hard thing to tackle if you do it the right way, and there are best practices already established.
And getting data on why pregnancy-related deaths are happening is essential, of course, but what can we do to improve outcomes once we receive that data? And can you talk about the role MMRCs have once that data is collected?
So some of collecting the data is important so that we can use it to see where it needs, not only nationally, but also in communities. And we talk about these perinatal collaboratives that will, the CDC and the national effort to collect data will be the mothership, and hopefully we'll be able to send out the tentacles to go out into the communities and find where there's deficiencies and where there's disparities, and do better to be able to connect patients and meet those needs. And hopefully a realization where access really is an issue. Maternity care is difficult to deliver, and we talk even about Philadelphia that's closed half of its maternity hospitals in the past decade. The only hospitals that are delivering right now are university institutions, because a lot of hospitals find the reimbursement not adequate for the care, and liability exposure, and a multitude of things, which is not for the conversation here. But it's really important that we are able to identify where these deserts are. I think that's wonderful in care, and be able to improve upon that.
Okay. Thank you. And once again, thank you all very much for being here. Appreciate your time and taking time out of your day and week to come up here and testify. And Mr. Chairman, I yield back.
Gentleman yields back. Chair thanks the gentleman. Chair recognizes the gentlelady from Illinois, Ms. Schakowsky. 5 minutes for your questions, please.
Thank you. I want to join my colleagues who have thanked you so much for this, all of you. I want to thank you, Mr. Johnson, for turning this tragedy into something positive. I think it took a lot of courage and probably a lot of time away from being a dad. And so I just want to express my appreciation to all of you and just mention that in particular. I think that the WHO and the CDC reports, et cetera, were really a wake-up call for people. I've been aware of communities near me, Milwaukee, for example, where we've seen this rise in maternal mortality, infant mortality as well, and it's really been unacceptable that we in a country, the richest country in the world, would see these kinds of results. It's absolutely shameful. I wanted to, and I think there's a lot of ways that we're failing mothers and children, especially African American women who are 3 to 4 times more likely to die from childbirth. We just simply have to do better. But I'm concerned about the new proposals, the Trump public charge rule, that puts maternal and infant health in grave danger. By targeting legal, tax-paying immigrants in this country, this rule seeks to discourage immigrants from using the very government services that pay for that are paid for with their tax dollars: Medicaid, CHIP, SNAP, WIC, and the Earned Income Tax Credit, just to name a few. So let me ask Dr. Coslet Charlton and Dr. Career-Perry, women who qualify for Medicaid that would cover pregnancy care and labor and delivery may face the impossible choice of jeopardizing their legal immigration status in this country or go without needed care. And let me just add that right now in my very diverse district, we are finding that people who qualify are not signing up for benefits right now because they're so fearful. So if women are forced to go without needed prenatal care, what could that mean to her health and risk of maternal mortality?
So it's an opportunity for us to use the same empathy we talked earlier about with the opioid addiction moment we're having, where we don't want to criminalize moms who are addicted to opioids, so we ensure that they have access to health care. If we criminalize women for using SNAP or Medicaid, we're also harming their ability to have a healthy pregnancy. So we should be able to use that same feeling of empathy for all mothers, that everyone who's in the United States deserves to have a healthy pregnancy and a healthy baby. And so how do we make sure that they don't miss their prenatal care? For example, in Louisiana, we didn't for a long time cover immigrant mothers, and after Katrina, it was a big push of new
This is even legal.
Yes. And so we had to add that to the bill when we got more citizens coming, because it was important for us to ensure that the babies had access and the babies had care. We saw an uptick in babies.
But this would prohibit even citizen children of those parents from getting the benefits.
So we have to think about what our value is, right? So if we don't value citizen children, what do we value? If we don't think it's important for them to have treatment from a physician, then what are we asking from us as a country? So it's just, we have to think about our own values as a country.
I agree. Yes, doctor.
And I would just like to add, ACOG strongly opposes any efforts to provide any barriers to any kind of care for pregnant and women and postpartum and prenatal, and this rule obviously would do such. So, and as a practitioner, the woman is going to deliver the baby no matter what. So she's going to deliver. You can't, no matter what, she's going to deliver. It's common sense that she needs prenatal care, for fear of having rising, morbidities and mortalities related to this.
Go ahead.
I was going to say, Congresswoman, we've made a strong statement against the public charge rule as well.
Thank you. And I yield back. Thank you so much, all of you.
Chair, thanks, gentlelady. Gentlelady yields back. Chair recognizes the gentleman from Florida, Mr. Bilirakis. 5 minutes for your questions, please.
Thank you, Mr. Chairman. I appreciate it. Thanks for holding this very important hearing. Ms. Stewart, as a parent, I remember the birth of my children was such a joyful event. The idea that rates of maternal mortality are on the rise is horrifying as far as I'm concerned. In our state, it's on the rise. I've read that women are dying from hemorrhage complications in the state of Florida. How does the Preventing Maternal Deaths Act help reverse the trend of women who are losing their lives due to these typical medical complications?
Well, I'll defer to my medical colleagues to describe the issues around hemorrhage and how that's contributing, but I will say this, that what this bill is designed to do is to establish across the country maternal mortality review committees that are designed to collect data on every maternal death and to make sure that every state understands the underlying causes of death for each woman that dies as a result of childbirth. But even beyond that, what it's designed to do is to not just collect the data, but to help states and to help the participants in the healthcare system design interventions that can actually eliminate deaths in the future. And that's one of the things that's really important about this bill is not only collecting the data, but then designing interventions. And of course, if we collect data consistently across the country, and if the sharing of interventions can also be shared, we can certainly accelerate our ability to reduce and even eliminate maternal deaths. I'll give you a couple examples of how collecting data in MMRCs has been really helpful. In Colorado, for example, data was collected, and what was found is that women that experienced maternal death had also been experiencing suicide and depression, and they were, in Colorado, able to find and identify where there were gaps in mental health services and actually close those gaps and give more mental health care services to women where they needed it. In Ohio, they actually did something which I think is really important, which is do additional training for hospital staff, beyond just the doctors themselves, hospital staff, where they went through simulations of training in obstetrical emergency situations so that they could actually be more responsive in the event of an emergency situation. So MMRCs are not only about collecting the data, but actually putting into action the things that can actually eliminate maternal deaths, and that's why this bill is so important, and that's why a national bill and a national effort is also so important, so the data can be consistent, can be collected, we can see the data, we can actually track the interventions more successfully.
Thank you very much for that answer. Dr. Coslet-Charleston, according to the Centers for Disease Control and Prevention, it lists indicators: severe maternal morbidity has steadily been increasing in their years. What are the key drivers of this increase, and how can it be addressed?
Well, some things are recognizing and being able to maintain proper prenatal care and care of women throughout the reproductive years and identifying comorbidities such as, we talk about obesity and smoking cessation and where we see a rise in comorbidities with heart disease. So having active interventions before pregnancy, we find, is critical to having a healthy labor and delivery for all women.
So you feel that they are increasing, I mean, in this day and age with all the technology we have, or is it just that we're getting more data on this, or that definitely are increases in maternal deaths?
Well, so far, that's part of the purpose of this this review, is so that we were talking earlier about the accuracy of the data. So some speculation has been made that perhaps because for the past 5 years we were actually recording on death certificates whether or not a woman was pregnant when she died or within a year after delivery, whether or not that has caused a rise in the actual numbers that we're seeing. But when comparing to other countries that have had similar check boxes on their certificates where they've seen a stabilization or a decrease, we've actually seen an increase. So these committees are really imperative to really, exactly what you're saying, really know and be able to assess and accurately determine if those disease entities, as well as true maternal death, if there is a change, and make sure that we have accurate data so that we can successfully portray appropriate interventions.
Yeah, exactly. So you know, whether it's increasing or what have you, we have to focus on the issue. There's no question. And Dr. Johnson, you have my sympathies. I was in the VA committee, so I didn't get a chance to hear your testimony, but I know how difficult it must be for you. Let's see, Dr. Creer-Perry, please. Our maternal mortality data has been described again as limited, unreliable, and even embarrassing by top researchers. Do you agree with these characterizations? And I know, let's expand upon this. Are there concerns with the research community regarding the integrity of the data being collected in states? What are those concerns and how might they be addressed federally?
It's me. It's okay. Bye.
Oh, you're over here. I'm sorry.
Yeah, so it's important. Dave Goodman and the folks at CDC are doing a great job of doing the data. They've been doing it for a very long time. They've dedicated their life to it. And they've looked at if the increase is due to error in data versus if it's an increase that's true. And all the studies so far have come back saying, no, there is an increase and it's from the data. And so the robustness with which the CDC is working on to look at this issue is something that we should all value, and that they're part of this bill. They're not here testifying, but CDC is really integral to getting this work done. And it's important that we understand that yes, there have been researchers that have given us pushback around the data over the years, but we've gotten better and better, and this is just another way to get even more clear about how women are dying, because we can get on a granular level and look at the hospital level what's happening. So yes, there have been a lot of articles about the data, but we truly know through the CDC that the rates are increasing and that we can do something together to do it better with this bill.
Very good. Thank you. And I yield back, Mr. Chairman.
Chair, thanks, the gentleman. Gentleman yields back. The chair would just make the observation that I believe it was Dr. Callahan from the CDC who came and spoke at one of our roundtables about a year ago, and you're correct. They are very thorough, and they have been at this for a long time. They've got a lot of good insights. Chair recognizes the gentleman from Massachusetts, Mr. Kennedy. 5 minutes for your questions, please.
Thank you, Mr. Chairman. I want to also thank you for your, obviously, lifelong and personal dedication to this issue, given your profession before coming to Congress and still the work that you do. I want to also thank Representative Herrera-Butler, who was here earlier, and obviously our distinguished panel for joining us. Dr. Johnson, Mr. Johnson, excuse me, I'll apologize. I was been in and out. Your words are extremely powerful, sir. Kira sounds like quite a woman. I've got 2 kids under 3. I was in a delivery room about 9 months ago. Thoughts are with you and your family, sir. In 2018, the United States of America has the highest rate of maternal deaths in the developed world. Every single year, we mourn roughly 700 mothers who are lost to complications during their pregnancy. And at least 350 of those deaths are preventable. Most alarmingly, profound racial disparities persist in these statistics. Black women today are 3 to 4 times more likely to die of pregnancy or delivery complications than white women. Before we try to explain that away on socioeconomic terms, just access to care, access to education, higher income, we have to be clear that even when you control for those factors, a wealthy black woman with an advanced degree is still more likely to die or to have a baby die than a poor white woman without a high school diploma. In the United States, a black woman is 22% more likely to die from heart disease than a white woman, 71% more likely to die from cervical cancer. Those are haunting statistics, but they still pale in comparison to the one we discussed here today. For black women are 243% more likely to die from pregnancy or childbirth-related causes. 243%. So we can't have a discussion about how to address a larger crisis in maternal mortality without having a discussion about how to confront the pervasive systemic inequities that are buried deep within our system of healthcare in America. And the last point I have to make is this, that there are, as we speak, 20 Republican attorneys general that are attempting to repeal the Affordable Care Act in our court system, after most of my Republican colleagues have voted to do the very same thing more times than I can count. So let's remember, 9.5 million. That is the number of previously uninsured women that gained health care coverage, including maternity care, which is an essential health benefit, under the Affordable Care Act. Coverage for women of color grew at more than twice the rate of women overall in 2013 to 2015. So to have a conversation about maternal mortality at a time when my Republican colleagues are using every tool in the book to roll back access to guaranteed maternal care and maternal coverage is a bit much. And with that, I want to direct my questions to Dr. Creer-Perry. I admire the work that you've done, Doctor, in discussing how we need to move away from seeing race as a risk factor in maternal health and call the real risk factor what it is, racism. So can you extrapolate that on a bit for the committee, and specifically, what do you believe to be the leading cause of those racial disparities I mentioned in maternal mortality rates?
So we've done quite a bit of focus groups and work in hospitals around how patients feel disrespected and not heard and not listened to and not valued. And a great example of that is Serena Williams, right? Mm-hmm. She gives an amazing story around how she had symptoms. She knew who she was. She's a very wealthy and healthy person as well, and she still was not heard or valued. So what we miss in this country is really being honest about when you don't see someone as being fully equal to you, you're less likely to think about their care in a very serious manner, you're less likely to address their issues in a serious manner, and you're less likely to spend the time that they need ensuring that they're healthy. And so what we have to be able to do is have some truth around that conversation first, and not act as if that's not a truth.
And so is there data that you would point to on this, or is this something that's a bit bigger than fits into an Excel spreadsheet and a pie chart? And how would you suggest
this is going to be both a policy fix and a cultural shift, right? Like, we have had policy shifts. We've had the civil rights movement. We have a lot of things of policy we can have, but as long as the culture still believes that Black people are less valuable or inferior, and women, we're going to keep having the same conversations over and over and over again. So we have to have both a policy conversation and a culture shift.
Anybody else want to comment on that? Mr. Johnson.
So just talking about this from a personal experience, and having an African-American, extremely vibrant woman who is not in good health, but in exceptional health at one of the top hospitals in the world. And to be quite honest with you, when this first happened and I was asked the question, do you think that this would have been different do you think this was because your wife was Black, or do you think that the outcome would have been different if your wife was Caucasian? I was in so much pain, I couldn't process that. And the thought that the color of my wife's skin contributed to her death. But what I am clear about is that she was not seen or valued as human. She wasn't. And the people who were responsible for her care, that I trusted with her care, failed to look at her in the same way that they would their daughter or their sister or their mother. And the reality of the situation is I'm asked the question, and people sometimes, the more I've spent with wonderful groups like Black Mamas Matter, and the more I look at the data, people, and I'm very clear about this issue of implicit bias and the contributing factors of racism. And people say, you're making it a racial issue. I didn't make it a racial issue, the statistics did. So what we've got to do is figure out how these women are valued and looked at as human. Because when I sit at night, thinking about my wife, and I have to think about that question about, would she be here today if she was Caucasian? Let me be clear that this is an epidemic that affects all families from all backgrounds and all walks of life. And unfortunately, I know that personally because I talk to these families, and I've become very close with some of these fathers and some of these families, and they're from all walks of life. But we cannot address this issue without head-on facing the way that it is disproportionately and horrifyingly affecting African-American mothers.
Thank you, sir. Chairman, thank you for the extra time. Thank you all for being here.
Chair, thanks the gentleman. Gentleman yields back. Chair recognizes the gentleman from Georgia. Mr. Carter, 5 minutes for your questions, please.
Thank you very much, Mr. Chairman, and thank all of you for being here. And Mr. Johnson, thank you for your efforts and for your work on this especially. And I echo the comments of all of my colleagues here today. We appreciate your courage. Mr. Chairman, I believe this hearing was set for another time, and I requested, and I'm sure others did, that it be delayed so we could have it. It's important to me, and I'm sorry if it disrupted any of y'all or inconvenienced you, but I'm from the state of Georgia. In 2010, there was Amnesty International report that flagged Georgia as being the #1 state in maternal mortality. And that's why I expressed to the chairman, Mr. Chairman, I want to be at this hearing because this is real to me. In fact, when I served in the Georgia State Legislature in We passed Senate Bill 273 that created the MMRC and put it into the Georgia Department of Public Health. And I wanted to ask you, Dr. Perry, because when we created that, you know, we followed the guidelines and we did what we were supposed to do. But I believe that your group was involved in a study when the state fails maternal mortality and racial disparity in Georgia. So you're familiar with that? And I know you are. And I you know, I had the chance to look at it and study it. And one of the things that it pointed out was the racial disparity in Georgia was the fact that even though the 4 categories, access to and quality of care, insurance access and pricing, funding, and accountability around data analysis and use, even though we had those in there, we were still failing on those, particularly access. And my question is, what can we do? Tell me what I can take back to my state, because this is important to me. I served in the legislature. I was Health and Human Services vice chair of that committee, and I helped with this legislation. If you know, the point's been made by my colleagues today. You know, what can we do legislatively? But what can I do? What can I take back to the state of Georgia?
Thank you so much. And I do work with Dr. Lindsay and the folks at Grady around the Georgia work, and they're specifically trying to look at their mental health care service structure. So supporting mental health care services in Georgia is important. Supporting Medicaid expansion in Georgia is important. Supporting rural hospital closures in Georgia is important. Like supporting support systems that include midwives and doulas in Georgia is important. All the social structures that we see, all the states where we allow for us to disinvest in women, honestly have poorer outcomes. Even though you can look and do the study and see we have we are working on things inside of hospitals because you have some great doctors in Georgia, you have some phenomenal people and some nurses and midwives, but until we build a structure that holds the entire state together, right? Like from rural Georgia, then we're not gonna be able to see an improvement. And we're being separated around ideals that don't allow us to come together. And it's important that we know we value all the moms in Georgia, rural moms, urban, they all need access to insurance.
Well, thank you for mentioning that, because as you well know, knowing the state, we have a disparity between rural and urban.
Exactly.
I mean, the state of Georgia is Atlanta and everywhere else.
Exactly.
So it really is.
Exactly.
Well, another part of that study that I was very interested in, because I'm a big advocate of this, is the proposition that the state could develop ways to help religious organizations and leadership engage and advocate for quality health education and services. And I'm really big with wanting to include the religious community. And can you give me examples of how we could do that, or examples of how that's worked before?
Including, because if you think about mental health, it's a great example, right? So a lot of religious organizations have access to therapy, access to groups, to places where women can come to make sure they have grievance counseling. So there's been a lot of work that that religious organizations are there to be a safety net and a support for women. They can't replace medical care, but they can serve as a safety net. They can provide transportation, they can help with child care, like all these other things that we're looking for that a community provides, because we know that women who have access to a community and to each other, to connectedness, have better outcomes. So how do we create connectedness and community across this country and across Georgia?
Right. One last question, and this could go to just about any of you, but the thing that I'm wondering here is, I know we're accumulating the data, and I believe you said earlier the data is going to CDC, and are they crunching it, the science of it? I mean, can we tie anything into this genetically, regionally?
I'll chime in, and others. You know, CDC's had a surveillance system in place for a number of decades, and thankfully we're able to collect a lot of data, mainly coming from death certificates. And just recently now, death certificates now include whether or not a woman was pregnant within the last year, and so that information has been helpful. But what we don't get from all of that, and by the way, that's a voluntary system. CDC asks states around the country to voluntarily submit the data. There are epidemiologists that then review the data, and we learn as much as we can from death certificates. But what we don't understand is that a death certificate does not necessarily tell the full story of how a woman may have died, and what were the underlying causes, and what were the potential interventions that could have been in place to prevent that. And that's what this is about. It's taking the data we collect improving it, improving the collection, making it consistent, having committees that then can design interventions and having them well funded so that they can actually see meaningful improvement over time. So that's the difference.
Good. Again, thank all of you, and Mr. Johnson, thank you, and God bless you.
And I'd just like to say that I'm actually a native of Georgia and currently
Did
living
this-
in Georgia.
did this
It's actually
happen in
happening in
Georgia?
California, but I'm
Okay.
a native of Georgia. Kira grew up in Decatur, Georgia. I grew up in East Point, and we were back living in Georgia, so we
Right.
look forward to working together with you to
Absolutely.
figure out how we
And
help
can
out
I
in
ask you, was your wife originally from Georgia?
Absolutely. Decatur,
Okay,
Georgia, born and
See,
raised.
this is the point I'm getting at here. I mean, you know, we're the cardiac belt. Has anybody looked at any of this to kind of try to tie this into it?
There's a lot of work being done on what is going on that are sort of the underlying causes to why so many women of color, especially, are dying. And there are a bunch of issues. I'll mention one of them. By the way, I'm from Atlanta too. Don't hold that against me.
I see a
it's
pattern
Georgia.
here.
We've known each other a long time. Look, there's a very important study, and we could go through a laundry list of things, but there's a very important study that has really helped all of us understand what are some of the underlying causes of why we see so many disparities among African American women in particular. A study that was done by a researcher who's now at University of Michigan, but she started the study in New Jersey, I believe, where she started to look at this issue of weathering. The fact that African American women's health tends to and African American women tend to have more challenges the older they get. Challenges in pregnancy, challenges in childbirth, challenges maybe post-childbirth, maybe due to this issue of weathering, which is that the impact of chronic stress that may be coming from racism and discrimination over a long period of time, this issue of weathering, which tends to deteriorate one's health, may be a big contributor why we see so many disparities. The fact that women are older as they're getting pregnant, and the fact that if black women are older having babies and they are experiencing this impact from this weathering effect, that could explain in part why we're seeing so many outcomes. Having said that, we still need to address the fact that we don't simply have to accept that is the case. We can actually do something about it. We can actually address those issues. We can actually deal with the underlying stress that exists. We can actually deal with the systems that may be creating the stress in the first place, and we can make sure that we understand what interventions are really effective across all communities.
Great. Thank you, Mr. Chairman. I yield back.
The gentleman's time has expired. The chair recognizes the long-suffering Mr. Engel from New York. 5 minutes for your questions, please.
Thank you, Mr. Chairman. I appreciate those words. Thank you. Thank you, Mr. Chairman, for holding today's hearing. Just in listening, it's just shocking that right here in the United States, women are dying from preventable pregnancy-related complications. That alone is shocking, but that women are more likely to die from those complications here than in other parts of the developed world, that's shocking. And the fact that this risk is 3 to 4 times higher for black women than white women, that's shocking. So it's a tragedy and it's an emergency, and thank you, Mr. Johnson, for sharing your story with us. I want to thank my colleagues, Congresswoman Herrera-Butler and Congresswoman DeGette, for introducing the Preventing Maternal Death Act legislation, which I'm a proud co-sponsor of, and I hope that after today, our committee can move forward on solutions to this problem that we really need to move quicker. It is more quickly. It is a long past time we acted to reverse this horrible trend once and for all. So let me ask this question. I've long supported investments in family planning and reproductive health, and I'm particularly interested in the impact that such investments can have on maternal mortality. As the ranking member of the House Foreign Affairs Committee, I've seen that impact on a global scale. In fiscal year 2016 alone, U.S. investments in family planning worldwide provided contraceptive services and supplies to 27 million women and couples, which in turn helped to prevent 11,000 maternal deaths. So let me ask Drs. Correa-Perry and Coslett-Charlton, would you each explain why meeting unmet need for contraception helps to prevent maternal deaths?
So there has been some data that shows that the safety and security you get from having access to family planning and not having to worry about if you're going to get pregnant again because you're not planning to be pregnant at that moment really decreases your stress and your weathering and ensures that you have a healthier pregnancy. We know that we've looked at the states that have more supportive policies around family planning, also have better infant mortality rates and better maternal mortality rates. So it's not a coincidence that when you invest in family planning and when you invest in infrastructure for moms and babies, you actually create a safety net where people can live longer and be healthier. So it's important that these policies that are created in this House improve the ability for moms and babies to live.
And I would certainly echo that response, but also it's been shown that women that are able to plan their pregnancies by spacing interval between pregnancies and having access to adequate contraception, that it improves the safety. There's very clear data to show that it improves outcomes in pregnancy and delivery also.
So thank you. Along those lines, let me ask if either one of you would explain why women in the United States specifically have unmet need for contraception. By that I mean they want to use modern contraception but are not currently.
So because it's a state and local issue usually around access to family planning and reproduction, and because when we allow that to be made state-based wide, people's you get gaps in what states pay for things like sex education, what states allow for things like having birth control inside of high schools. Once again, I'll say for my great state of Louisiana, we struggle with getting sex education into schools. We struggle with getting access to family planning for the people who actually need it very desperately. So I think in the attempt to make for a safe environment for our state, sometimes we mislabel what safety looks like. Safety looks like having access to choice when it comes to your reproduction. And when you have that access to choice and information, you can have a safer pregnancy and a safer outcome.
Well, thank you. Obviously, there's a lot more work to do on this front. Let me mention this. A December report from the Guttmacher Institute estimated that globally, and I quote, fully meeting the unmet need for modern contraception would result in an estimated 76,000 fewer maternal deaths each year. That's 76,000. So I want to ask either one of you doctors to please, if you agree, is it fair to say that improving access to contraception for American women could help address the rates of maternal death in the United States?
Yes.
That's a loaded question, but I wanted to put it out on the record. I wanted to also take this opportunity to briefly talk about legislation I've introduced with Congressman Stivers, the Quality Care for Moms and Babies Act. The legislation would bring together diverse stakeholders to identify care quality benchmarks for women and children in Medicaid and CHIP, as well as fund new and existing maternity and infant care quality collaboratives. These collaboratives bring together local stakeholders, such as doctors and nurse midwives, to share the best practices and improve care for patients. And I'm grateful to both the ACOG and March of Dimes for supporting this legislation. And let me ask you, finally, let me ask maybe perhaps Ms. Stewart, I'll ask you this. Wouldn't you agree that we should be measuring and evaluating the performances of Medicaid and CHIP in caring for America's moms and babies, as well as investing in prenatal quality collaboratives which work to implement maternal mortality review committee recommendations at the state level?
Congressman, we're very involved across the country in perinatal collaboratives, and they are very effective, and we very much support them. And I would just add this point, which is that 60% of all births are covered by Medicaid. And that's a lot of women and a lot of babies. And whatever we can do to make sure that the quality of care exists for those women as it does for women in the private insurance market, to make sure that we're collecting the kind of data to understand what is effective and what is not, and that we're sharing that data across states, we would firmly support that.
Thank you. Thank you very much. Thanks, Mr. Chairman.
And gentlemen's time has expired. Seeing no additional members wishing to ask questions, I want to thank all of our witnesses again for being here today. I have some documents I need to read into the record. Statement for the record from Sean Blackwell, MD, momsrising.org, and Alexis Joy Foundation. I also have the September report for the Maternal Mortality Morbidity Task Force for the state of Texas, A letter from Dr. Gary Hankins, who participated in one of our roundtables. Dr. Hankins is from University of Texas Medical Branch in Galveston, and Dr. Cardenas had mentioned the obstetric hemorrhage toolkit in California, and I do have a copy of that I'm going to submit for the record. Also, documents from the March for Moms, Postpartum Support Virginia, Association of Maternal and Child Health Programs, Heart Safe Motherhood, Massachusetts Child Psychiatry Access Program, a letter signed by 1,000 Days and other patient groups, Americans United for Life, Alexis Joy Foundation, Nurse Family Partnership, Preeclampsia Foundation, Society for Maternal and Fetal Medicine, a letter from Tamora McQueen Saba, American College of Surgeons, KSM Consulting, More California PPH, SAP America, and Forbes Insight Study. And just to end on a somewhat positive note, my grandfather was an OB-GYN, an academic OB-GYN at McGill University in Montreal, and practiced obstetrics during the decade of the 1930s, when the maternal mortality fell from all-time highs to all-time lows, certainly indicative that if we put our minds to it, it's happened before, it can happen again. Pursuant to committee rules, I remind members they have 10 business days to submit additional questions for the record. I ask the witnesses to submit their responses within 10 business days upon receipt of the questions. Without objection, the subcommittee is adjourned.